Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I'm with Jamie. How are you doing today?
Good, Dennis. How about you?
I'm doing very well. So one of the reasons why I asked you onto the podcast is you have experience as a group doc, and I kind of want to vent at you is that I'm trying to add propofol, morphine, hydromorphone, IV fentanyl, and pretty much all the other cool drugs I keep hearing about to my formulary, but docs just won't let me. So what can I do to let them just give me what I want?
So the ubiquitous those guys, or in this case, those docs, those pesky docs won't let me add something. So I think really what we want to distill this conversation down to is two facets. And one of them is the requirement. What's the capability that the medic is trying to get? And then the next part is, okay, what's the doc's role in that process? Does that sound like a reasonable place to start, Dennis?
Oh, yeah, absolutely.
Cool. So as I look at this, it's funny. I'll quote Harold Montgomery. Many people know him as the former 75th Ranger Regiment, senior medic, still actively involved and a huge leader in the joint trauma system. And one of the things Monty's fond of saying is if you're going to add something in there, what are you willing to take out? And I used to think, well, that's kind of old school, right? Like we really shouldn't limit our medics based on weight and cube or, any other parameter. But if they're asking for something, let's explore that and give it to them. But his point is not wrong. And the point there being, be a master of the basics. So my very first question when a medic comes to me and says, hey, we need to add this drug. My next question is, well, how are you using the ones you already have? And where are those failing you? And if they can't give me a good, clear answer to that, then we sort of have to stop the conversation right there and go, okay, well, all right. So what I'm hearing is you don't really have a capability gap. You're not missing something that you need to do. It's kind of a cool drug. It's the next shiny thing. That's not really a good reason to add something to the formulary. Does that make sense, Dennis?
Oh, absolutely. And I mean, from my aspect, like I'm looking at protocols and they're telling me I need to have it, but I'm stuck with ketamine and maybe like one small vial of Versed.
Right. So, and this comes back to, again, I think First Special Forces Command is a states' rights organization, right? Solutions come from the ground. Strategy comes from the headquarters. You could expand strategy coming from the headquarters to also be top cover or legal authority. So then my question is, okay, if it's in the CPGs and guys are seeing those CPGs, or maybe they've been on an MPT, a medical proficiency training rotation, and they were using a hot new drug in the ICU, and guys are like, yeah, we need that. I'm familiar with it. I used it for 4 weeks in the ICU. I'm comfortable with it. Then the next questions come down to, is it an operationally appropriate drug? Okay, so the drugs you listed off, like Versed and ketamine, there's a reason those have a time-proven presence in the medic's aid bag, because we've used them for years. We know they're stable in the hot, the cold, all this other stuff. And they're a proven track record, right? It's a known entity. When we start talking about latest and greatest hospital drugs, sometimes those drugs haven't gone through the proof of life out in the field environment. And a good example might be, and that's not a reason to say no, by the way. That's a reason to say, hey, we need to dig a little bit more and we probably need to try this out. Ask around, see if EMS anywhere is carrying some of this stuff forward. Or other people have used it in the field. Our European partners are great allies on this effort, by the way, because the Europeans typically are pushing a lot of their drugs in the field because their doctors are pre-hospital providers. So they've got no limitations on a lot of these drugs that they can use in the pre-hospital environment. So then the question becomes, hey, does this have a pre-hospital track record of success? Can we use it on a non-monitored patient? That's another question, right, Dennis? I don't want to knock a patient down if I don't have appropriate monitoring. And then the third one, which is a great Dr. Shackelford principle, is never, ever mix a lethal bag. We've talked about jet fuel and bump sticks over the years. And the concept is always the same. Hey man, what happens if you go down as the medic and you've mixed up all this stuff? You know what's in your bag, but let's say the tactical situation changes and now your Bravo takes over and he spins that wheel and opens that bag wide open. What's going to happen to your patient? Or your Bravo confuses 1 ml for 10, accidentally delivers the whole bump stick. Again, these events have happened real world. And so those are the other questions we have to think about from a military medicine perspective is how safe is this drug? How durable is it in a field environment? And then really what's driving the requirement? All right, what are we missing right now that you need for your patients? And is the drug that you're proposing going to answer that gap? Does that make sense?
Oh, it makes 100% sense. But, like for an example, fentanyl, right? I have ketamine that takes care of pain. But there are definitely situations where, like long bone fractures, I found that they works better with, chest injuries and abdominal injuries. If the guy is stable, right? I know that this drug will work better for me, but ketamine takes care of pain. So how do I kind of bridge that gap with the doc and I have benefit of, I use these drugs a lot. Right. So I do have experience with both using them appropriately and using them inappropriately. So I understand the consequences. How do I explain that to a doctor that I'm one of, 40, right?
Yeah, Dennis. So this is in the 3 E's of military medicine, as we like to discuss them, it's evidence, environment, and equipment. With evidence, I've seen you and Paul and a few other guys propose add experience onto that. You are 100% correct. A medic's experience and comfort with an agent is a big part of this equation. But that's where I would say now we're asking the wrong question. If we're asking to change or add something to a formulary for the whole regiment, and there's only a small percentage of medics that are really comfortable with that agent and use it frequently enough to be really proficient, then the question, here's the easy win. You can hit your battalion surgeon up and they can approve that under their license locally. So there is nothing wrong with that. We just did that recently with a couple battalions in the 95th, where they asked to add DEX. And I said, hey guys, you don't have to run that up and get that in the formulary. If your local surgeon signs off on your guys carrying that and you're trained and he's validated that y'all are proficient with it and safe with that agent, you can add it, get your med log to put it on your list of approved meds. And most surgeons though, Dennis, here's the Achilles heels on that process. They're going to want to see that the medic is competent and confident with that agent if it's something that's not standard. I think that's appropriate, don't you?
I do. I guess how local does local get? Can it be a couple of medics in a company, or is it the battalion is signing off on it so everybody in the battalion can pull from it?
Yeah, so that's a tough question. I should have an easy black and white answer for you. I don't, and that's a failure for me as the command surgeon, right? But what I would tell you is, the policies are pretty clear. If you want to change the TMEPs, our tactical medical emergency protocols, for everybody, that's got to go up through schoolhouse, through the curriculum evaluation board, and then all the senior medics will meet in the JMEAC, punt it over to the CEB, the curriculum evaluation board, and they'll approve it and add it to the formulary. Boom. And then every soft medic or anybody that uses the TMEPs holds an ATP card can use that agent. For the local level, let's drill down to the exact opposite. Let's say you got a small team that's going to a certain partner force in a certain AO where they're going to be using a lot of a particular agent that we don't use a lot here. And so working with your doc, you've done your mission analysis and you realize, hey, you know what? We probably need to get real comfortable with this drug because they have a lot of it on the ground. The supply is good. It's a safe agent. And we think it's going to be effective for all the stuff our partner force and our guys are running into. At that point, in that conversation, that could just be an agent that your battalion surgeon or Better case scenario, the brigade level surgeon, so the 06 level command surgeon, either the group surgeon or brigade surgeon, can approve that for that limited use for those folks. But again, that's a conversation between those medics that have that specific requirement and the battalion level to see if they're amenable to that. And what I would tell you is at that point, right, the licensed provider, the physician or the PA, they've got a license to protect, right? As does the critical care RN or anybody else. And so under FDA prescribing authority, if you're going off-label with a drug, which by the way, we do every day with ketamine, that's off-label use, that's on a licensed provider to determine off-label use, FDA off-label use for an agent. So the same thing applies when you're talking about using an agent overseas in a deployed setting where you want to add something temporarily. Does that help?
It does. But I guess on the flip side, docs can say, well, you don't have enough experience, right? That's why I don't want to give this to you, which is 100% valid. But how do I then get the experience when getting on an MPT or even just going back to Sockamus is so freaking hard because I have to run ranges or I have to sit in a field and doing airdrops?
Dennis, I could give you $20 right now for setting me up on this one. And I promise listeners, we did not pre-plan this, truthfully. So what you're saying, Dennis, has been a problem in my last 20 years that I've observed. The sergeant major runs a tight training calendar, and it's really hard to add in stuff or justify additional medical training. They barely want to give our medics the bare minimum, right, to go back to SOCMS or just do their MPT. And now we're talking about adding in additional training to prove to the doc that, hey, the medics are good with this. They got this. So how do you do that? Well, here's the question. How do you do that for any other training or capability in the Army? Well, we all know the answer, right? Yeah, you got to use it. It's all about using it. But the other thing is you have to show the commander why you need to do it, right? And so what do our commanders speak? It used to be PowerPoint slides with red, green, and amber. So the older folks on the podcast will appreciate that. The red, green, amber. Oh, your med readiness is red because nobody's gotten their flu shots. So what we've done at First SFC is, and this was a medic-led initiative. All the medics got together and said, hey, we're tired of trying to fight for time to train. We really need help. We want to show the sergeants major and our commanders that we got to carve out time for medicine because shoot, move, communicate, survive. If we're failing at survival, all the rest of the stuff doesn't matter on an ODA's worst day. So what we did is we standardized a basic T-Tri-C one-pager survival scorecard, and that's designed for the ODA. So that's a start right there, Dennis. You put a couple ODAs through, you test them out, and then you take that to the company leadership and you're like, hey, Sergeant Major, check it out. 3 out of 6 of your ODAs are survivable. That means 3 out of 6 can't even put tourniquets on right or whatever. We need additional time and money to train this. 7th Group has done this really successfully, and they got both. They got time and money for training and resourcing for medical. But it's because they took the time to grade themselves, to be honest, and then have that conversation with the commander. Hey, we need help. We need time or money or resources to get this stuff done. So that's floating around the regiment right now. Highly encourage guys to engage their senior medics on that one up at the battalion level. They should be aware of that survival scorecard. And that's one tool you can use and say, hey, here's how my team's doing, and then here's how I'm doing as a medic. I need additional time to go up to the hospital or go to our local level 1 and train on this stuff. And I think your battalion docs will not only support that, they'll be really happy to support that. Over.
So the survivability scorecard, where would you find that?
So right now that is circulating. It's been pushed to all of the group and brigade level senior medics. So they all have it for our 11 CSUs. By the way, that wasn't just 1st SF command centric. 75th was involved. We had senior medics from the Rangers, 160th. Basically all of the USASOC tribes involved on that. And nothing on that scorecard is new. And in fact, those that have been through SOCMA-C recently will recognize some of the TPA and CTM scoring stuff on there. But again, it's a single pager. It's quick. It's easy. It's intuitive. And it allows you to just go back to that commander and say, hey, we need resources.
Right. So I guess another aspect I think of just getting experience is with our 18 Delta refresher course. I mean, we have a week of pushing meds, real consequences. But the medics get the experience, and the medics come back and they say, we have all this experience now, we have all this comfort, but none of the docs are really, they don't really get to see it. How do I, one, as a instructor at that course, two, as an actual 18 Delta, how do I get my doc or other docs to come look at this so that they can kind of validate, like, yeah, this is actually legit experience?
Yeah, Dennis, great question there. And I'm not naive enough to think that there's not some of our docs listening to this podcast that are seeing both sides of this, that where I know there's some doc listening going, oh man, that's horse crap. I use those drugs all the time in the emergency department at the community hospital I work at or I moonlight at. But you've also got docs on the other end of the spectrum that are saying, man, I haven't used that agent since residency. And even then, I only used it a couple times on my ICU rotation or whatever. And so they're not comfortable with it at all. We've got a broad spectrum of provider comfort. That's one reason there's a regulation in USASOC 350-1 that states every new doc and PA to Special Operations Command, right, is supposed to go through SOCMA-C or SFMS3 to go back through the refresher, spend that 3 weeks here at Bragg, and get to push the drugs right alongside their medics. It improves their confidence and it helps them understand what their medics are doing. So if a provider is uncomfortable, that's going to be my first question to them. Hey, when was the last time you went to the refresher, SOCMA-C? And if you haven't been, I'm going to challenge you, get back to Bragg and do that. And the good news is there, at least this year, there was money to do that from USASOC centrally to support providers. Okay. But again, that money goes away if we don't use it, Dennis. So get those providers in there and get them working right alongside their medics. And I think that'll fix it, don't you?
It should. So I guess my next question is, so it says new docs as of what date?
So the way the regulation reads is when you're newly assigned. So it's your first assignment to a special operations unit. So anything in the USASOC umbrella, and you're coming in for your first PCS to that unit, you're supposed to either TDY en route or immediately upon checking into your unit, come to the schoolhouse at Fort Bragg and do that 2 to 3 week refresher right alongside the medics.
Yeah. So, I mean, when was that policy written? So they're new as of 2021?
Nope. No, that's been out there since 2018. So it's
right. So brand new from.
Yep. It's out there. Not a lot of people know about it because on an average year, how many new docs and PAs do we have coming into the regiment? Brand new, never done anything in soft medicine. That number is probably between 5 or 10. Because a lot of our folks, as you know, Dennis, are prior 18 Deltas, prior operators and kind of get it. So they would be exempt from that requirement. That said, I highly recommend it. It's great to get back to the schoolhouse and refamiliarize.
I'd hate to say this, but I would actually not give anybody that leeway, regardless of where they came from, because you spent 4 years in medical school, X number of years in residency, and now you're coming back. You are out of the game for almost a decade.
Yeah, great point, Dennis. I don't disagree. But all I have to say is one really, really bad word, and all the providers that are listening to this podcast will shake their heads in agreement, probably violent agreement. And that bad word is Genesis. It has fundamentally changed the amount of time and energy and effort that's required to just take care of our folks. And so in reality, time has become a really critical and precious commodity that's pretty rare for our providers. So I'm not blind to the fact that 2 to 3 weeks out of a person's schedule is going to have big impacts on their battalion's healthcare. So that's an uncomfortable tension that we got to work with. And if anybody's got good solutions out there, you heard me say it, solutions come from the ground. That's you guys. That's everybody listening to this podcast. Let Dennis know. There's ways to get in touch with us on the global, on the website. Hit us back. If you've got solutions, better ways to train that stuff, I am all ears because it's a sticky problem.
Right. So kind of full circle, me being a medic, I want, a new drug, and maybe it's not an analgesic, maybe it's, I don't know, norepinephrine or whatever it is, right? I've gotten some experience or I've read about it. I think it's as applicable to us in a mission coming up. I want it. What is the best way for me to approach, and who is the person that I should approach? Is it battalion? Is it group?
Yeah. So brass tacks, Dennis, how's this look? You want to add a drug. You're confident with it. You really feel like this is going to make a difference for your patients. First step is approach your battalion docs, and so your PA and your physician, and let them know this is what I'm thinking. This is no different than your 6 rights you do with a patient before you administer a drug. So it's gonna outline those same 6 rights. Here's what I'm giving the drug for. Here's who I think would benefit from it. Here's all the pharmacokinetics of the drug, how I'm pushing it. You build confidence from that first conversation with your providers that you know what you're talking about, that you've really got this down. Ask them, are they familiar with that agent? That's step 2. That's a really critical step. If they're not familiar with it, guess what? They're probably going to say no because they're not comfortable with it. So if you find out they're not familiar or comfortable with that agent, then the next step is you're going to have to do a little bit of digging to help them understand the why this is such a critical requirement for you to add it to your local list and stockage. And then again, that's a back and forth. If they get to a point where they're like, hey, this makes sense, and they're probably going to phone a friend. They're going to talk to other docs they know. They may talk to some folks in the hospital that they rotated with and say, hey, does this make sense in pre-hospital? And then the third step would be use it, whether that's in the context of an MPT, clinical rotations, or back at JSOMC, going through SOCMA-C or SFMS3. Get hands-on that agent and build some reps and do some confidence. That's the strength of what you and the team have done back at SwimG, Dennis, and that's that phase 3 approach. Get guys comfortable with the drugs hands-on. We're not using simulated vials of saline. We're using actual agent that has pharmacokinetic effects. And there's nothing that builds confidence better than that. So you guys have done a great job doing that. Let's take advantage of that process. And I think that's what then would get you to the finish line, which is then having a conversation with your med log at your group or brigade level. This will also involve a coordinating call to your group surgeon or your brigade surgeon, just a courtesy copy. Let them know that you're asking to add a medication to a local use at the battalion, and you're going to do it under that battalion provider's license. And then MedLog will adjust your authorization or your ASL, authorized stock list, so that with that brigade surgeon's signature, they can draw that agent. So that's the process in a nutshell. Pretty simple. It's a conversation, and then it's a little bit of paperwork with MedLog, and you're off to the races for local use of a drug. What I would emphasize on that, Dennis, is at no point can you just add that agent or use that agent downrange unless you've got that licensed provider's signature and approval to do so. Does that make sense?
Mm-hmm. Well, it makes 100% sense. One other question kind of tied to that. Let's say it's not a new drug. I just need more than what they issue me, right? Like I went downrange and they gave me, 1 vial of ketamine and this itty bitty tiny little vial of Versed, which would last me, maybe 10 minutes. How is it that I prove I need more of it?
Yeah, that's a good one. So this is the power of a story. I give you the short answer right up front is nothing sells that argument like a story. And by story, I mean a vignette, something that's happened downrange. This, again, is a powerful part of the refresher where medics all get together and they talk about what they've seen and experienced. If you can share a vignette with a provider that puts flesh on that discussion, like, hey, we exhausted our authorized 5 vials of ketamine in 4 hours in a prolonged field care scenario where we were taking care of, 3 patients. Because that's real world, right, Dennis? I mean, you're going to burn through that stuff like water when you've got multiple casualties. And we all know that the standard quantity on those ASL lists that come from MedLog, that's a recommendation, right? So now, again, if you're going to change it, you're going to up that quantity. That requires approval of your battalion doc to do so. But again, if they understand the why, I think most of our providers are agile enough to support that.
Yeah, perfect. I mean, it's not complicated math, I have this mission requirement. I already know going into the plan, my evac is going to be X number of hours, maybe days long. It's really not that hard to do the basic math, even just using the knowns of, how many milligrams an hour, by the book you'd be going through, and just do the math. You do the math. You look at the drugs. The amount of drugs you gave me is only going to last, a quarter, a tenth of the time. I think going through that footwork actually lays things out as well as the story.
Yeah, agreed, Dennis. And this is another great example of where a medic doing a little bit of homework and doing that math can really build confidence for their battalion providers, which will help them win the day on getting the drug. The analogy I use is a friend that I went hunting with had his 300 Win Mag. And we were doing some pretty long distance shots. So, anything between 300 and 600 yard shots. And on the buttstock of his rifle, he had his entire range table written down for that exact ammunition he was running that day. And he had those tables for every different type of ammunition that he could potentially carry. But what that proved to me was this is a guy that knows his weapon system really well. He knows his ammo. He spent time out there running rounds through that rifle, and he knows his exact minutes or number of mils that he's going to adjust shots based on range. And it's right there on his buttstock, and he's written it all out. It's super fine print, and it's on a glow tape backing, right? I mean, none of this is new to anybody that's done any of the sniper stuff. But the point being, he'd already done all the math. All the tables were already there, and it was right there on his weapon system. Same thing with your drug box and everything else. If you show your providers that you've dotted your I's and you've crossed your T's, that's going to build tremendous confidence and allow them to get behind you and say, yeah, I think this is a good ad for the formula. This is something we can do safely, and it's going to be effective.
Yeah, perfect. I mean, it comes down to communication, but and trust, right?
That's it.
Do you have any other points about how do I build trust in my provider?
Yeah, Dennis, what I would say is, I talked about that survivability scorecard. And it's got a couple names floating around out there. You might hear it called the T-Tri-C rubric or the Rubicon, but it's basically that rubric, right? And if you as a medic have made your team fairly proficient in basic T-Tri-C, that's a win right there, right? Because we're seeing a lot of teams are struggling. This just isn't a skill set we've put a lot of time to training, and guys are fumbling with tourniquets, And I don't mean medics. I mean your team guys. And so if that medic's able to get across a little bit of medical competency at the team level, that says a lot to those battalion providers because they see that when they're out there training. And vice versa, to the battalion providers that are listening to this podcast, get out there and train with your guys. Trust is a two-way street. You got to work with them, be familiar with them, ask them questions when you're doing those tabletops using some of our training methodologies. Ask them about the pharmacodynamics and the pharmacokinetics. And medics know that stuff. Know those big 5 agents that you carry that have big boy consequences. Know the half-life. Know the onset. Know the duration of the drug. Know the differences between giving it IV and IM. And if you know those basics for those drugs that do have some high risk profiles, That's going to build tremendous confidence in your battalion providers. And oh, by the way, that's great for your team guys to hear too, because they're listening. They're like, man, Doc's pretty smart. My medic is smart. He's a good dude. And that builds trust on the team too.
Yeah, absolutely. Well, that's it for me. Do you have anything else you'd like to add?
The only thing I'd say, Dennis, if somebody really, because here's the deal, right? We don't want to be guilty of fighting the last 20 years war. Future conflict's going to be different. And with that, our formulary probably needs to be different. We need to start thinking now about what countries we're going to be in. And there's not going to be our helicopters flying or C-17s delivering pallets of our Class 8. It's just not going to happen, right? So my challenge to all the medics out there is think about where you're going or where you could be going and where you're going to get your drugs. What drugs do they use locally? And so that's where, Dennis, this is a really powerful podcast. Because if guys embrace this idea that they may be using some local stuff in future conflict, that's a total paradigm shift, is it not?
Right. I mean, Google's a powerful drug or a powerful tool. And that's one thing that I have kind of incorporated into some of my lanes is that I will add a vial of a mystery thing that has a label and the date and all the concentration. All the guy has to do is Google it, and the vast majority never do.
There you go. Great example, Dennis. So yeah, take that extra 30 seconds or minute, clack in a few keystrokes on the Google machine, and you'd be amazed what you can find. Now, again, I'm not saying, hey, go ahead and start pushing, Pakistani ketamine. That's not what I'm saying. But I am saying be familiar with where you're going and what agents are available on the ground. Have that conversation before you go with your providers so that you're all on the same sheet about, hey, on your PACE plan, when you get down to that C or the E and no resupply is coming, are you going to be able to use those locally available agents? And again, that may not be your primary or alternate, but you should have a full PACE plan, and that should include some local pharmacology.
Yep, absolutely. Well, thank you, Jamie.
Thank you, Dennis. I appreciate the time.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast, out.